Hello, and welcome to another episode of the CSA's podcast, Vital Times. I'm your host, Dr. Rita Agarwal. I know we were all shocked and dismayed by the murder of United Healthcare CEO Brian Thomas in early December. What was just as surprising was the comments deny, delay, and depose written on the bullets that were found at the scene. Once the alleged shooter was arrested, information quickly started to trickle out that he had suffered or he was suffering from back pain, particularly low back pain, and perhaps that played a role in his motivation to murder the United Healthcare CEO. There's information that on his Reddit and subreddit feeds, he talked about having spondylisthesis and finally getting surgery for it that seemed to help, and then silence for a long period of time. Speculation ran rampant that the problems with his back or inadequate treatment or repeated insurance denials were at the root or the catalyst of all of this for some reason. These are not questions that we know the answers to, but we did think it would be really interesting to explore the causes, treatments, and epidemiology of back pain, particularly in young people. We're used to back pain in older people, middle-aged people, but young people is where we're going to focus on today. Joining me today to help us muddle through all of this are Dr. Amber Borucki, who's a pediatric anesthesiologist and pain specialist from Stanford School of Medicine and the Stanford Children's, and Dr. Rahki Dayal, who's the chair of the CSA's Pain Committee and an anesthesiologist and pain specialist from the University of California in Irvine. Welcome, Rahki. Welcome, Amber.
Thank you so much for having us.
Great. Yes, absolutely. So I'm going to dive right into it. My first question really is, how common is back pain in particularly young patients? And has that changed over time, or is it remaining reasonably stable? And I'm going to start with Dr. Dayal.
So back pain is very, very common in the American population. In general, chronic pain is very common. 1 in 4 adult patients are going to have pain at some point of time of their lifetime. When we say pain, we talk about acute pain, chronic pain, and subacute pain. Acute pain is classified as pain within 6 weeks, subacute between 6 weeks and 3 months, and chronic pain more than 3 months. I think that's important to understand because the treatments for those kind of pains is very different depending on the pathology. And more recently, we are seeing increasing numbers in adolescent and pediatric patients. So I'll let Dr. Borucki take that.
Yeah, Amber, Dr. Borucki.
They're looking over multiple different literature recently. Our group at the Stanford Pediatric Pain Clinic, we've started to look at chronic low back pain in the adolescent population more specifically. And when reviewing globally rates, they range anywhere between 12 and 36% of children and adolescents have reported chronic back pain. The issue, though, that we found when we were kind of looking and reviewing this literature is there's not a lot of great literature. There's, kind of spotty reports, case studies, things like that, but there's no large, randomized control trials, no large studies that are looking at this. So it was very interesting looking at the data because the data range very differently internationally, looking at different countries, what the rates were.
Could you give an example of that? Like, for example, the US versus maybe Canada or versus European countries or Asian countries? Is it higher or lower?
I'm sorry. I don't have those exact numbers right in front of me.
That's okay. We can move on.
I remember there was a study in Cameroon that had a very high prevalence, and they were trying to figure out the reasoning behind that. And looking into backpacks and looking into kind of different backpack weight, et cetera, all this stuff as to why children had a higher prevalence.
Oh, that's great. Dr. Dayal, do you know, has the incidence changed over time in the U.S.? We'll stick with our population.
Yes, of course. So the incidence has increased over time. It used to be 1 in 5 adults, previously. Now it's 1 in 4. It's over like 100,000 like patients every year.
Wow.
A lot of patients, and it's increasing a lot with time.
And I know this is probably a pretty complicated reasoning, but what are the most common causes of low back pain in adolescents and young adults? Either one. Dr. Dayal, if you want to start, then we'll go to Dr. Borucki.
Yeah, so most commonly that we see, patients would have acute injury during sports or activities that they are having back pain. Some people, most resolve pretty fast and they heal well, but some patients do land up having prolonged back pain. We call it like chronic back pain. I have seen several patients who during activities have herniations of their disc, which lead to low back pain or radicular pain. And then some people can have idiopathic or congenital diseases such as scoliosis, which can contribute to back pain.
Dr. Borucki, is it different for the adolescent population or pretty similar reasons?
Pretty similar reasons, as Dr. Dayal had said. Athletes very commonly they'll develop pain, particularly those athletes that are doing extension, a lot of extension. So our gymnasts who are doing these hyperextension things, ice skaters, tumbling, cheerleaders, etc., where they're kind of doing a lot of things that require hyperextension of the back. We see a lot of that population in our clinic for sure. And then definitely, patients who are, a common patient might be someone who's in multi-sports. So very active, I'm in 3 different sports varsity level, so that's the athlete population for sure. And definitely I would say with the athlete population comes the medical conditions like spondylolysis and spondylisthesis. That's kind of more common in that athlete population related to some of the activities they're doing. And then we'll see a lot of patients who come in who have back pain, who have no imaging findings, who have chronic back pain, no imaging findings. And it seems to be a much more, muscular-based pain etiology, that there's kind of more tightness in the muscles, muscle tension, muscle spasm, more of what we call myofascial pain that these patients are having. And I would say that's probably much more common. And they're looking at the reasons behind that. There's been looking at prolonged sitting has been kind of associated with that. So sitting in school for prolonged periods. Screen time has more recently been found to be associated with things like that. And then there's been ongoing evidence looking at weight of backpacks that children are wearing.
Okay. Is there like a gold standard treatment for most low back pain, or is it very variable depending on underlying cause? Dr. Borucki, if you want to start, and then we'll go to Dr. Dayal.
I think when we think of chronic pain, we think of all the different ways we can treat chronic pain. But number one is always lifestyle. What's going on in the lifestyle? It's leading to this. If some of the chronic back pain could be related to ergonomics, so the way the patient is sitting in school or in class, or what we've been finding a lot is a lot of screen time at home, and we're slouching and laying in bed and sitting in ergonomically not good positions for our back. So we may start with kind of talking about posture and sitting, and where that we should do our work at a desk or a table rather than in bed, making sure we've got good lumbar support. So we'll start with lifestyle first and, advise things like that. And then physical therapy is always the backbone of lower back pain, as a pun, of lower back pain treatment therapies. So physical therapy is always kind of one of the first steps that we take when we have a patient that comes in with back pain. And typically the physical therapist will do an assessment and then advise treatment that can be strengthening, stretching, postural based advice and recommendations, et cetera. That usually is helpful. So I would say those, looking at those things are kind of always our first treatment that we advise. Dr. Dayal, do you have further thoughts on that?
Dr. Borucki, thank you so much. I think that was really nice. From my side, I'm mostly an adult, physician, but I do see adolescents at times. A lot of it is based on getting a good history and doing a great physical examination on the patients, asking about how they feel about their pain, how they cope with pain, what they perceive their expectations going to be with the healing process. And then comes the component where we need to make sure they're educated on what we understand the diagnosis is and what we expect the prognosis to be. And I think educating them, making sure they, say it back to us, closed loop communication to make sure they're understanding it and comfortable with their treatment regimen really helps me feel confident that the patient's going to comply with the treatment and do well. So I spend a lot of time asking them questions and addressing that.
So that was a really lovely description of sort of early treatment. But what if they fail those treatments? What if they're still having a lot of back pain? And actually, I want to circle back to something that Dr. Borucki said. Would one of you mind defining what spondylisthesis and spondylosis are? Dr. Dayal?
Go ahead.
Or
Either ways. The conditions basically specify, like Dr. Borucki mentioned, like overextension, certain activities. What they do is they change the alignment of the vertebrae in a certain way. They can do that, which causes mechanical changes out there. Also, at times, it leads to stress like fractures in the posterior components of the spine, which may or may not cause nerve pain like related symptoms, but can cause localized back pain for the patients.
Do you treat that any differently than you would someone who doesn't have those conditions?
So those conditions are graded on a scale. So there's kind of grade 1 through grade 4 level. And it's, more conservative treatments for grade 1 level. And as you move forward and you get more, as Dr. Dayal said, more alignment changes. So the vertebrae sitting on top of each other, one starts slipping more and more and more. So as you get that alignment change that worsens and it becomes higher grade, that's where surgical treatments may come in. But prior to that, when we're at a lower grade, we would treat that, again, more of a conservative treatment, non-surgically.
Great. Can you elaborate a little bit on the role of insurance in maybe approving or disproving or not or denying some of the, I assume it's more the advanced treatments like nerve blocks or surgery, or something else. Do they often deny these things, or are they pretty responsive to approving them? Dr. Borucki?
Sure. Actually, you would think it would just be procedures, but medications also frequently get denied. One medication that it really, is kind of like, why would we deny this? This is such a benign treatment, would be like a lidocaine patch. So a lidocaine 5% patch that patients can put on their back to feel comfortable. What a low risk treatment that this is for when you're treating a younger patient, you want to try to avoid a lot of side effects. And so this could be a treatment that they could use that's got a low side effect profile, is portable. They could wear it at school. You wouldn't believe how many times insurance will deny that. So yes, it goes all the way down to as simple as a pain patch that a patient may wear.
What is their reasoning for that? It's not even that expensive, correct? Or is it? I don't know.
It is really expensive.
It is expensive?
The 5%, yes. It can, depending on the insurance code, from $400 to $600. But it can. So some of the treatments can be very expensive.
And how does that, so just since we're talking about lidocaine patches, how does that compare to like the over-the-counter lidocaine patches that you can just go in and buy that, Shaquille O'Neal uses, or I'm trying to think who the people are who advertise them. It's often big athletes. Are they more effective? They're definitely a lot more expensive, but are they that much more effective?
They're the lidocaine over the counter. You can get a 4% patch now, which is pretty similar in strength. The highest amount that we would prescribe is a 5% patch. That's a prescription strength, and the ones over the counter are 4%. So frequently, if insurance won't cover for my patients, I'll say, you know what, just go ahead and get the 4% over the counter patches and utilize those. And patients have found those to be beneficial as well. So in situations where we can't get the 5% patch, then I'll advise the patients to use the 4% patch over the counter.
Okay, great.
I do want to highlight here, in as much as we talk about pharmacological and advanced procedures for insurance coverage, as you heard from Dr. Borucki, the initial recommendations for treatment are actually non-pharmacological.
Right.
Physical therapy, activity, sometimes, acupuncture, yoga, those kind of things, and pain psychology.
Mm-hmm.
And we deal with a lot of insurance coverage issues for non-pharmacological treatment options. Physical therapy has a annual cap. Multiple other modalities which are non-pharmacological and effective for several conditions are not covered by many insurances.
Mm-hmm.
Does insurance cover acupuncture, Dr. Borucki?
It depends on the plan. So typically what you'll see is most plans will cover a certain number of visits per year, say 12 or 15 visits per year. But unfortunately, most acupuncture providers, they're not advanced to be able to manage the billing. So if a patient were to go in, receive an acupuncture treatment, they'd have to ask for a super bill, bring that back to their insurance, and then they're the ones that are working with the insurance to get reimbursed. So that can be, for some of our patients, quite a barrier to receive these treatments, because it's a lot of, it's kind of putting a lot of the work on the patient and family who are already suffering and having difficult times to go and work with insurance to then try to get that paid out. So yes, there is coverage. It depends on the plan, on each plan. Each plan is different, and some plans do have coverage.
Is that your experience as well, Dr. Dayal?
Yes, and just from a numbers perspective, each session of acupuncture can cost around $50. Most acupuncturists will say you need 6 to 10 sessions to assess response. So we're looking at a $500 cost for the patient to assess response to a treatment. And quite a few patients may decline that.
Yeah.
If it's not covered.
At what point would you escalate? So you said initial treatment is often non-pharmacologic. It's physical therapy is the mainstay, plus these other things, meditation, pain psychologists. At what point would you want to escalate to something different? I don't want to say more, because I think those are really great holistic approaches to pain in general. But at what point would you say, okay, this clearly isn't working? And I assume, and I say this kind of assuming that athletes in particular are not going to have a lot of patience for multiple sessions of anything. They just want to get better fast so they can get to their sport. So how does that all play into everything? And we'll start with Dr. Dayal and then go to Dr. Borucki.
Yeah, so we focus on a multimodal comprehensive plan for all patients. And it really depends on the assessment, the presentation, the requirement to get better rapidly. As you mentioned, for sports patients, to escalate to pharmacological regimens or even intervention. It's an acute herniation. You see it on an MRI and the patient's hurting. You might want to do an epidural sooner than later, especially for patients having a motor deficit, than wait for these non-pharmacological regimens. So it's always a multimodal assessment. We're always thinking of everything. And I think it's individualized care.
Okay. Dr. Borucki?
Yeah, I would say it depends on, as Dr. Dayal said, etiology. So, if there is a known, disc herniation, the patient has significant pain radiating down their leg, and it correlates. So we always want their history to correlate with their imaging. So what they're telling you, this hurts here, it correlates with what we're seeing. We can see a known area of a nerve being compressed. Then you may intervene sooner, particularly if it's leading to functional issues. So patient can't go to school, they can't be active, et cetera. And then, some patients, when we're taking care of them and their imaging doesn't show anything that's going on, and their pain's worsening, we'll try different treatments, et cetera. And, we don't always use an interventional treatment because the pain's getting worse, because all of our interventional treatments are targeted. So, people may say, well, why can't I get an epidural? We don't see anything on the imaging.
And you're talking about an epidural steroid injection.
Right, an epidural steroid injection.
Okay.
Or an injection, et cetera. If there's no imaging to kind of support that's going on, et cetera, we don't want to do an intervention in a patient unless it's indicated, unless we have the history with the imaging, with their signs and symptoms, et cetera, all lining up to, to show us that this intervention is indicated.
Great. Thank you. I would love for you to share some stories about, is there anything else, actually, before we get to that, is there anything else that you can think of that would be worthwhile for our listeners to know about just the general approach to a patient with low back pain, assuming maybe they do have some underlying pathology to explain that pain? Because I know you had mentioned, Amber, that earlier that oftentimes it may be musculoskeletal and there is no imaging to really support. I don't want to say physiologic because obviously that's not correct, but to support a potential more invasive approach to their pain management. Are there other treatments that you would go to first?
I want to say what I want our listeners to know is if your pain is more than 3 months and persistent, ask your doctor to see a pain physician. And if it's earlier than that and you're having what we call red flag symptoms, which means a change in sensation in your extremities, weakness, bowel or bladder dysfunction, fever, infection, weight loss, maybe you should see the doctor sooner. As you can see, we are very familiar between the two of us. We can verbalize so many insurance issues. So your pain physicians are well equipped for advocating for you to get the numerous treatments. And our teams are very familiar with multiple insurance options. So I highly encourage patients to find the right practice to, advocate for them and evaluate them.
Right. And I think just kind of going over all the different, I look at them as different categories of things we can do for patients who are in pain. So it's as, basic as lifestyle changes, ergonomics, diet. So we will work with, sometimes we have a dietitian. We're very blessed that we have a dietitian in our clinic who might look at how diet can impact pain. And we look at ergonomics and how that can impact pain. And then add in physical therapy and movement-based treatments to try to help with pain. Manual treatments like integrative medicine treatments like acupuncture, massage, something we call in the medical world neuromodulation, but it's use of devices that provide electric signals to the muscles, nerves, things like that. So something like a TENS unit might be helpful. Then medications, pain psychology, and finally procedures. So there's all this broad category of things that we can think about and offer to a patient when they come to a pain specialist. So I would agree with Dr. Dayal that if you're suffering and it's been more than 3 months, that it might be helpful to get an expert in this area to help you.
But that can be a real issue, right? Because there's kind of a shortage, is my understanding, especially of pediatric pain specialists for sure. But I think I've heard even for adult pain specialists that patients often will have to wait months to see one. And if you've, and especially if you're a young, healthy, otherwise healthy person, waiting several months to see someone to get relief for pain can be quite challenging, right? Dr. Borucki?
This is true for pediatrics. I can say for sure. We have patients who are in our work list wait queue, that can be, we're trying to do as best as we can to place them, quickly, but it can take a bit of time to get to us. And not only, it's also the other providers who are taking care of the patient, not realizing there are pediatric pain physicians out there who could be helpful. And so I think, that not uncommon, we'll see a patient who has been to orthopedics, rheumatology, seen multiple different specialist providers, neurology, before the thought of, hey, let's actually have them go see a pain trained physician. So I'd say that's very common, that we typically may be the last stop on the train of specialists that have seen the patient.
For us, I think we are a slightly different kind of practice. So we do have like quick turnarounds on our. There are less like pain physicians nationally, so I think it depends on the location that you're in that it matters. So our turnaround is somewhere around 7 to 10 days, and if someone's having an acute issue, we would accommodate them the same day. And we also, I want people to know that there are options. Like if they need a procedure the same day, some of your practices might be able to accommodate that. So that's available. We'll end up doing that. I'm a fan of telemedicine to some extent. So I think that's an option for patients now. I think it's not good for new patient evaluation. You really want to do a physical examination for a patient to see what's going on. But I think if someone needs an evaluation and they can't come far, I think that option is still open in healthcare for patients to at least initiate some kind of discussion. I don't think it's comprehensive, but potentially that's an option.
Great. I'm going to switch gears just a little bit here. And again, a lot of this is hearsay and speculation. So I don't know that it's necessarily true, but apparently the shooter of Brian Thompson, the CEO of United Healthcare, had a successful surgical procedure done in 2003, but 2023. But apparently there was a long period of time between his diagnosis and when he had the surgical procedure done. And again, a lot of speculation here, but his denials and after the initial surgery, his posts on social media confirmed that the surgery had been incredibly successful in treating his pain. And then, like I said, there was sort of social media silence and difficulty even of family and friends getting in touch with him, so sort of 6 months after that. So there's a lot here we don't know. But what really made me curious is, do you find that insurance companies will prevent or delay or deny procedures that you think, or not treatments, they're effective therapies that you think are useful and important for your patient to receive, and you constantly have to fight with them? And if so, how do you keep going? How do you keep doing that? I will start. I actually don't remember who I went to first last time, so start with Dr. Dayal this time.
Okay. I've read similar things as you're stating, and there's a lot of speculation around that specific situation. In general, surgical treatments for back pain are for certain conditions and indications when it's absolutely clear that the patient needs surgery. As I previously mentioned, sometimes patients develop red flag symptoms such as weakness, bowel bladder incontinence, and it's absolutely clear that the patient would benefit depending on the pathology from the surgery, in which cases our surgeons would go right away. In several situations, it's a gray zone, which means like, are you failing non-surgical options and have you given it a good try? For example, if I get a patient and I ask them, a commonly used medication for nerve pain is gabapentin. And sometimes they'll ask, yeah, I tried it and it didn't work for me. I like asking them more, and I'll ask them like, how much did you use? How frequently did you use it? And many times I hear from the patients, I tried it for a day, I took 2 tablets, I took 3 tablets, and it didn't work. So that's not a fair trial of the medication. It just works differently, works better over time. So I think making sure our documentation is strong and ensuring that we've documented well the indication for ongoing pain, the pathology, and the failure of non surgical options helps insurance approvals on these things. Um, and when not feasible, our surgical teams and us, we spend a lot of time having conversations with for peer review um, to advocate for the patient to make sure we can, advance their treatment options as needed.
Mm-hmm.
Has that been more challenging lately, or is it still always the same?
It's increasingly changing. I don't know if it's because of like increase in incidence of back pain, increase in availability of treatment options for back pain, because now you have many more minimally invasive treatment options as well. So you can do a foraminotomy, you can do a minimally invasive discectomy. So maybe the surgical options which are minimally invasive are more. So there are treatments which are out there. So we're seeing an increased incidence. There's also a documentation requirement. So I highly encourage everyone to assess like what's needed for appropriate documentation for the patient in these situations. Dr. Borucki, if you want to add more.
Yes. So I would say one of the things that I think is important to know is that, prior authorization, I think the number of things that need prior authorization now has increased. I remember I saw a report on this that, when prior authorization first came out, I think it was, I can't remember if it was the 60s or 70s, it was utilized then, and it was at a low rate, 10 or 20% of things. Now I just looked, and it's, kind of like it says the Medicare Advantage plans, 80 to 90% of treatments are requiring prior authorization. So you're seeing more and more necessity for prior authorization that's being needed. So, a physician or a provider can't just simply go, I think this is needed for you, write the order, patient gets it. There's now more and more red tape with everything we talked about, all the different modalities for treatment, more and more red tape you have to go through. And this like I see this in my clinic all the time. I think the importance of documentation, as Dr. Dayal said, is really important. You have to lay out your case in your notes, become kind of like the case and the reasoning for why they need this procedure. And you have to make sure you document patient has tried X, Y, and Z already and failed. And you know what I'm saying? And now would be indicated for this treatment. So that's very common. So we do a lot of pediatric migraine treatment. And prior to receiving any treatment such as Botox injection, which we use for migraine, we have to show the patient has tried a medication from one of 3 drug classes, has tried at least 2 of them for these 3 drug classes, that they've failed, and that they've got the right diagnosis code to be indicated for this, the severity of the migraines, et cetera, in order to obtain that treatment. So our notes, definitely, we're writing parts of them really to help with those approvals.
So we're writing notes for insurance companies, not really necessarily for patient care, is what you're saying. Or that's what I'm hearing anyway.
Patient care is working with the insurance companies, right?
Yeah.
So we are writing it for patient care, but in order for them to receive their treatments. And I literally just had a patient who had failed 3 treatments, 3, oral medication treatments, had, doing acupuncture, doing physical therapy, all these different things that we were trying to obtain the ability to do Botox injections for migraine. And we still got a denial, even though we did all of those things, because the patient was under 18. And there is a AI-based algorithm within the company that, that's not FDA approved, just automatically deny it, even though there's literature showing it's safe and effective in adolescents. So it took speaking to 3 separate people in the company, and a full day of phone calls that I had to be part of to finally get an authorization.
A full day of phone calls. So this is your valuable time where you could actually be seeing patients and providing care. You're having to talk to insurance companies. I had heard, and I'm sorry, I will get to you, Dr. Dayal, too, but I had heard, and I don't know how far in the process it is, but at least in California, the legislature is trying to pass some laws to prevent AI-based algorithms for insurance denials, or at least, and I don't exactly know the wording of that, but have either of you heard of that, that they're trying to get AI out of that business because it is, leads to these arbitrary denials, which then takes so much time, not on just your part, but your staff's part, other people in your office's part, and then the patient is left kind of hanging and waiting and suffering. Have either of you heard of any of these laws that are at least being proposed?
I'm not familiar with it.
Okay, well, we'll keep an eye on that space. Hopefully that will come through, or at least if they're going to use AI for insurance denials, that there's some clear sort of guardrails in there to prevent some automatic denials. Dr. Dayal, do you have any egregious insurance denial stories to share?
Yeah, we do get similar situations where insurance would deny like pharmacological treatment for patients. And it's not just the insurance. Sometimes nowadays I see the pharmacists also deny filling medications for patients based on, I guess, something they see from the insurance perspective. So we are spending a lot of time coordinating the patient's care more and more. And some of this is probably because it's all electronic, and I don't know, like people have their guardrails on specific these things. But AI is creeping into healthcare in many different ways. I think some EMR companies are also looking at integrating AI. So I guess if the LCDs are like tied in, which is the local coverage determination, maybe it gets easier both ways.
Okay.
But don't know that.
I mean, yeah, the hope, right, is always for AI to make things easier, better, faster, more efficient. But it sounds like, at least for right now, there's still a lot of growing pains. Is that what you would guess? Okay. Any final parting thoughts? We're gonna keep this short and sweet, but any other stories you want to share? Patients that you've seen that got denied but then got benefit, or anything else either of you would like to share with the audience today, Dr. Dayal?
So, two things I want to say. One, there are newer treatments that are coming on consistently for pain management, both interventional and pharmacological. Like Botox was such an amazing treatment option for migraines that came out. We have CGRP antagonists, which came out all in the last 5 to 10 years.
Yeah.
So it's amazing what treatment options are going on. So research is going well. We have a new medication, suzetrigine, which is going to probably get FDA approved today, I hope. So we'll see how that comes out. I also wanted to let the people know, yes, surgical treatment options are helpful in many conditions, but if you have certain surgical conditions very early on in life, it does expose you to repeat surgical interventions subsequently. So I think it's an integrated team effort in sometimes coming to that decision. So please talk to your providers about your unique condition for an individualized plan. Thank you.
Great. Dr. Borucki?
Yeah, I think that although we've painted a difficult landscape here for care with insurance-based authorization issues and things like that, I think knowing that in general, your provider is committed to getting you their treatment. And most of us are really working hard and committed and have teams behind us to try to help patients get to their treatment. And we've got, I think what we said earlier is a wide range of different things to know about for, that we can do for chronic back pain. And we're here to advocate for you to help get the treatments that we think are best for your individualized, unique care. So even in this era of, kind of what's going on, with obtaining healthcare and insurance authorization, you've got an advocate in your healthcare team.
That's awesome. I'm gonna take the host prerogative here. There's two things I wanted to follow up on really quickly before we sign up. I know Dr. Borucki's been talking to me about, you'll have to pronounce it, Sozertatine, that's hopefully going to be approved today. I think we're going to try and do a future podcast on some of the other newer medications, not just that one, because there was the one that came out a few weeks ago with capsaicin and local anesthetic, I think, mixed with it. I think it'd be really fun to do a podcast on some of the newer pain treatments. But the other thing I kept meaning to swing back to, Dr. Borucki, you had mentioned diet for pain. Would you mind just saying a couple of words about, like, I've heard rumors that there's an anti-inflammatory diet, like certain foods you should eat and certain foods you should avoid. Would you mind commenting, both of you? I see you both nodding your heads. So I'll start with Dr. Borucki and then go to Dr. Dayal really quick. But what are some dietary changes that can be made to help with pain?
So it's really interesting that you ask that, because we incorporated a dietitian into our pain clinic this past year. And from that, we just recently reviewed all of our data on that. So we had about 37 patients who were referred to our dietitian in our pain clinic. Of those patients, remember, these are all children and adolescents. Of those patients, about half were referred actually in the pediatric and adolescent world for issues with eating and reduced oral intake. Pain can make patients feel that it can affect their appetite, make them less hungry. And so our dietitian really worked in that category to help improve nutrition for those patients. Also, we did find there were some patients that actually suffered from malnutrition, and we did find 2 patients with an eating-related disorder that we were able to refer to appropriate services. So that's kind of 50% of the patients were referred for that related issue. The other 50% were referred for looking at how diet can affect their pain in terms of looking at the anti-inflammatory diet, how that could help. And so our dietitian did meet with patients, did discuss dietary changes, so avoiding overprocessed foods, eating certain types of vegetables, eating things like with omega-3s and salmon, things like that, fish, chicken, things like that. So kind of a specific diet that is known to, that is believed to lead to less inflammatory markers and mediators in the body to help with pain. And there's cookbooks out there for the anti-inflammatory diet. There's online TikToks, there's YouTube videos, all this, et cetera, about the anti-inflammatory diet, which is more like a Mediterranean diet, they would say. And so, yes, we definitely have worked with patients. And then I will say another large area that has been kind of developing in terms of diet, nutrition, and pain is use of medications such as the GLP-1 antagonists like Ozempic, et cetera, and how they're finding benefit for patients with pain with these medications, and how this can be beneficial. So there's kind of a whole new, era opening up of looking at diet and pain together.
That's great. Dr. Dayal?
Yeah, I love that answer. And it's so good you have a dietitian like on your team. That's fantastic. In our setup, like we have an integrative center, which is close to us, and it does like diet, acupuncture, massage, yoga, tai chi, gives those options to patients. And I do send my patients routinely there. Some patients are more receptive than the others, and they really take to it a lot in terms of modifying their diet. I hear things like improve lifestyle, improve energy, improve functionality from patients with certain changes. So it's definitely like promising. It's a lifestyle change. So I encourage patients to look at that and consider it. Yeah.
Well, thank you both so much for joining us today. This was really interesting. I definitely learned a lot, even though I work in the pediatric pain world and deal sort of more with the inpatient pain patients. I learned a lot about low back pain. Thank you again. This has been another episode of Vital Times, the CSA's podcast, and I hope you'll join us next time.